Please welcome to the stage Dr. Manikum Moodley.
Good morning again. This morning, Dr. Devorah Segal and myself will be talking on the subject of neurofibromatosis type 1. I am going to concentrate mainly on the pediatric side, and she will talk on the adult side. So, that's my logo from the Canadian school that I first started my trip to North America. I have no conflicts of interest. And the outline for my topic this morning would be overview of neurofibromatosis type 1 in children. And as mentioned earlier, Dr. Segal will talk on NF1 in the adult patient. So, the neurofibromatosis are really a conglomeration of four terms: NF1, NF2, schwannomatosis, and segmental NF1 or mosaic NF1. For purposes of today's talk, I am going to concentrate on NF1. There are various other variants of NF1, and two that comes to mind which are relatively common are Noonan's and Watson syndrome, but I'm not going to talk about it, but can discuss it during the discussion period. So today's topic is NF1 and a little about the history of this condition. The earliest reports of individuals with neurofibromatosis dates back to about 1080, but it really came to vogue about 150 years ago when an Australian pathologist called von Recklinghausen coined the name neurofibroma. Hence, sometimes this condition is called von Recklinghausen's disease. In the late 1900s, the condition was classified into two types, NF1 and NF2. And let's talk a little about the NF1 gene discovery. I'm just going to be very brief on this. All this happened in the year 1989 to 1990 when Francis Collins, who was the head of the NIH while he was working in Michigan, discovered that the NF1 gene is localized on the long arm of chromosome 17. If you look at the chromosome, there is a long arm and a short arm, and this is chromosome 17. And in position 11.2, that's where the NF1 gene resides. So, in 1990, further research workers in the form of Cawthorn, Viscochel, and Wallace mapped the gene to the position 17q11.2, that is the long arm of chromosome 17 at position 11.2 is where the gene for neurofibromatosis type 1 existed. And this gene produces a gene product called neurofibromin, which is actually a tumor suppressor gene. So if this particular gene product is not formed, the patients develop tumors. So that's basically the pathophysiology of neurofibromatosis type 1. Let's look at general characteristics of NF1. It is an autosomal dominant condition, but the clinical expression is variable, and many features show age-dependent penetrance. And I'm going to show you the slides on this age-dependent penetrance as we go further in the talk. There is a high spontaneous mutation rate of about 50%. The birth incidence is about 1 in 3,000 to 4,000. And to put all this into perspective, currently there are about 100,000 people in the USA with NF1. And compare that with Duchenne muscular dystrophy and cystic fibrosis. It's commoner than both of those diseases, which gains a lot of attention throughout the country. Neurofibromatosis affects both the peripheral nervous system and the central nervous system. It can affect nearly every organ in the body: the skin, the bone, the endocrine system, the GI, and the vascular system. I will talk about the diagnostic criteria of NF1 that has been used for almost 30 years now. It was promulgated by the NIH in 1988, and Dr. Devorah will talk on the new criteria which was promulgated in 2021. But this has been used from 1988 to 2020. So there are 7 clinical criteria for NF. And to make a diagnosis of NF, we need 2 of the 7 criteria, as I will talk to you shortly. So the first criteria is the presence of café au lait spots. You need at least 6 café au lait spots, and they must be more than 5 or more than 5 millimeters in their widest diameter in the prepubertal period, and more than 15 millimeters in the postpubertal period. That's criteria 1. Criteria 2 is freckling in the axillary and inguinal region, sometimes called CRO, as it was first named by this particular individual. Optic gliomas, third. 2 or more Lisch nodules or iris hematomas. These are really benign lesions that you see on the iris, and they do not cause any problems with vision. The next would be 2 or more neurofibromas or 1 plexiform neurofibroma. Next, a distinctive bony lesion, and this could be sphenoid wing dysplasia, tibial dysplasia, pseudarthrosis of the bones, especially the tibia. And lastly, a first-degree relative with NF1 by the above criteria. So those are the 7 clinical criteria we have, and we need 2 of those 7 in order to diagnose anyone with NF1. But remember, we have genetic testing as well now, and there's a new criteria that Dr. Segal will talk about. Now, I want to touch a little on the development of the clinical features of neurofibromatosis type 1 to give you an idea that all these clinical features do not appear almost simultaneously. There's different times during the growth of the child that these lesions appear. Okay, so this is going to be a busy slide, but I will go through it step by step. So this is the timeline from birth to adulthood. And at each timeline, I'm going to speak to you about which physical signs come and which are the prominent ones you need to pay attention to. So between birth and infancy, you get caffeole macules and all the bony dysplasia as well as plexiform neurofibromas, but not neurofibromas. Very rarely you would get neurofibromas in this period. And then from infancy to early childhood, you get all the learning disabilities, ADD, ADHD, motor disorders, speech disorders, and also optic pathway glioma. Optic pathway glioma actually can happen even at birth or early infancy, but predominantly around this period, 5 to 6 years. And then in early childhood to adolescence, the next group of lesions appear, and these are skin fold freckling, Lisch nodules, scoliosis, and dermal neurofibromas and peripheral neurofibromas. So that happens predominantly between early childhood and adolescence. And the last period, which is adolescence to adulthood, you get the malignant peripheral nerve sheath lesions, breast cancer, especially in females, but it can happen in males as well, and high-grade gliomas. So I hope you've got some idea about the timelines of these lesions as they present in children and adults. Next, we'll talk a little about the clinical features. And if you look at the clinical features, the 4 predominant features would be caffeole spots, Lisch nodules, neurofibromas, and skin fold freckling, which occur in more than 90% of our children. Learning disability is close at 60%, and then you have a whole host of other features that are less than 50%. Family history, macrocephaly, optic glioma, scoliosis, seizures, hemihypertrophy, and vascular disease. Don't forget hemihypertrophy. So if you are managing patients with NF, always try to do at least 1 leg length measurements. Otherwise, you could miss that easily. Now I'm going to talk to you about each of those important features and then show you some pictures which will make you associate them with each other. Caffeole spots, they usually present at birth to infancy, as I mentioned. They increase in size and number during the first 5 to 7 years. After 7 to 8 years, caffeole spots can happen, but they're very infrequent. And that's important. What happens to them is they can grow in size with the growth of the child, but they don't grow in number. More than 95% of patients with NF have caffeole spots, so it's a very important clinical feature. But remember, they also occur in 10% of the general population and in other neurologic or genetic disorders, and I'll give you some differentials for that. They are randomly distributed, but most commonly in the trunk, and they pose no threat to life. That's the important thing. Caffeole spots don't pose any threat to life. Here's some more facts about caffeole spots. We said it is autosomal dominant. In the general population, it has been found in at least 10% of patients. You can get caffeole spots in NF2 and these 3 diseases: McCune-Albright syndrome, Legius syndrome, and tuberous sclerosis. So always keep these 3 disorders in mind, especially if you don't have all the diagnostic criteria satisfied, because it may be one of these conditions. Fanconi's anemia, ataxia telangiectasia, and Cowden syndrome are the other differentials. So I've given you this so that you can keep your mind open as to what other conditions may be causing this besides NF1. Okay, here's pictures of Caffiole spots. If you look at this child's foot, here's a large Caffiole spot you see. And here's more Caffiole spots on the abdomen and on the lower chest. The next finding is axillary and inguinal freckling. The freckling seems to appear a little later. Some can happen in the first 5 years, but usually by 5 to 7 years. They are like Caffiole spots, but they are small, 1 to 2 millimeters, and occur predominantly in the axilla, in the groin, inframammary area in females, and sometimes in the entire body. Here's pictures of axillary freckling, and there's some Caffiole spots there as well. And here's another patient with axillary freckling and some Caffiole spots as well. The third feature is neurofibromas. They appear, as I mentioned in the timeline, they appear in teenagers and adults. Can happen earlier though. They are tumors of the nerve sheath, and they can affect both peripheral nerves or nerve roots. They can affect the skin, on the skin or underneath the skin. They can affect viscera, for example, the kidney. If there is a neurofibroma close to the renal artery, it can press on the renal artery and cause hypertension. So if a patient with NF1 has hypertension, that's one of the causes that you got to rule out. It can affect blood vessels and cause ischemia to end organs and injury to end organs. They can be nodular, discrete, or pedunculated, as you will see in the picture below. So here's a picture of multiple neurofibromas. Here's a single one, and here's a pedunculated one. Here's a neurofibroma that's giving rise to macroglossia, a big tongue. So always look into the mouth of a child who comes in with NF1, because that might be the only clue, besides Caffiole spots, of the child having NF1. Plexiform neurofibromas, they often present in childhood. They involve multiple fascicles of large nerve trunks. They are often asymptomatic but can compress organs and cause symptoms. The important thing about plexiform neurofibromas is 5 to 15% of them have a lifetime risk of malignant transformation. Fortunately, these days, in the last decade, there has been targeted therapy for these malignant peripheral nerve sheath tumors in the form of MEK inhibitors, and the one that is currently FDA approved is selumetinib or Koselugo. Here's some pictures of plexiform neurofibromas. Here's the arm, and that's the forearm, and here's a large plexiform neurofibroma. Here's another plexiform neurofibroma on the palm of her hand, and here's a patient who's got a large plexiform neurofibroma involving the whole leg. And if you look carefully here, there's a cafe au lait spot there as well. Lish nodules, these are age dependent as well and bilateral. You don't usually see them in the early stages of life, but by 5-6 years of age you see them, and by 30 years 90 to 95% of patients have Lish nodules. They are actually very benign hematomas and they cause no harm to vision, and 10% of patients will have Lish nodules under 5 years. And as I mentioned, 90 to 100% over 30 years of age will have Lish nodules. So it becomes an important clinical sign for the diagnosis of NF1. Here's a picture of Lish nodules. They're coppery brown in appearance in the iris. Here's the pupil, iris, and that's the cornea. Optic gliomas. Now they happen from birth to the first 8 to 10 years of life. Again, optic gliomas don't usually happen after 10, 11, 12 years of age, but they can. But in adults, you hardly get optic gliomas for the first time. So that's a timeline base that you got to keep in mind. They occur in 15% of individuals, but only 5% of them become symptomatic. And they are also benign astrocytomas. They are benign lesions. And they rarely progress to malignancy. They can affect one or both eyes, and they can affect the optic nerves, the optic chiasma, the hypothalamus, and the optic tracts. So extensive involvement from the eye to the occipital area of the brain. So we need careful follow-up of these patients for at least 8 to 10 years. And here's a picture of an optic glioma in both eyes. This is a coronal image, and that's a sagittal MRI showing bilateral optic gliomas. MRI is a very important modality to locate these lesions. Skeletal findings, you can get thinning of long bones, fibrous dysplasia, sphenoid wing dysplasia, pseudarthrosis of the tibia, and scoliosis. And here are pictures showing exactly what I've mentioned. Thinning of long bones, and here's fibrous dysplasia of the left arm. That's the fibrous dysplasia. This is the thinning. Here's pseudarthrosis. That is where you get anterior curvature of the tibia. And this can be very brittle and develop fractures, as seen in the next picture. That's an X-ray showing the anterior curvature of the tibia with a thin hairline fracture. Here's scoliosis to the right, and another feature, bony feature in children, is pectus excavatum. This is one of the moderate sized pectus excavatum. They can be milder or even very severe. What about neurologic findings? Very briefly, they can be progressive or static. The progressive ones are CNS tumors, spinal tumors, cerebrovascular disorder. You may have heard of a condition called Moya disease, where you get stenosis of the internal carotid arteries, followed by what looks like a puff of smoke, and that's why the Japanese call this Moya disease, which means puff of smoke. So that's a characteristic feature of NF1 patients. You also get hydrocephalus in NF1, not because of tumors, but because of a problem with the aqueduct of stenosis, aqueduct causing stenosis. What about static problems, neurologic problems? You get learning disorder, mainly learning disorder, neurodevelopmental delay, behavior disorder, seizures, headaches, and macrocephaly. Macrocephaly is a feature of NF1 that one should keep in mind because it might be one of those features that might give you a clue that there might be NF1, so you can follow this patient longer. Mental function, remember about 10% have mental impairment. 40 to 50% have ADHD. I think this slide is very important for parents and patients with NF1. 40 to 60% have specific learning disability, and there is a high association with autism spectrum disorder. And of recent, there have been several papers on this particular topic. One does not know what the etiology of autism is in NF1. I'll just talk a little on unidentified bright objects or UBOs or myelin vacuolization. 43 to 93% of NF1 patients show UBOs. These are focal areas of high signal intensity on cerebral magnetic resonance. I'll show you a picture of it soon. Devorah was working at the Mayo Clinic at this time, proposed this finding in 2000 to be a diagnostic criteria. Because if you look at the other diagnostic criteria, they occur in about 20% and 15% and yet made the 7 criteria. But this still has not come into the diagnostic criteria. Here are pictures of UBOs. And here you can see they affect mainly the basal ganglia near the caudate nucleus, the thalamus, and sometimes they occur in the cerebellum. But in the subependymal layer, they occur frequently as well. This is my last slide, and I'm going to read this slide very slowly. The mechanisms underlying various complications of NF1 are now gradually coming to light, leading to the development of new approaches to therapy. Preclinical studies and human clinical trials are underway. Medical therapy for various features of NF1 are likely to become increasingly available. Clinical trials can be identified through clinicaltrials.gov, so that is why you should put your name in the NF registry if you are going to be notified of these trials. And lastly, this is a time of great hope for individuals with NF1 and their families, with the prospect of new treatments that will significantly improve quality of life and health in the years to come. Thank you.
Hello again, everyone. I feel like a celebrity when I come up to that music. It's a little disorienting. But thank you, Dr. Moodley, for that great overview of NF1 in children. And now we're going to pivot to NF1 in adults. And I find that this is sort of an underrepresented topic because everyone we so often focus on the children, and we forget that those children will hopefully all become adults in pretty short order. As a parent, it happens much faster than you expect it will, that's for sure. And children who become adults need ongoing care for their NF1. So we'll talk about what do we look out for in NF1 in adults, what are we not worried about anymore, and I'm really going to put a plug in for continuing care in an NF1-centered clinic if possible when you become an adult. Oh, sorry. There we go. Okay, so I have no conflicts of interest related to this topic. I'm just going to briefly put this up. I'm not going to go into a lot of detail on the diagnostic criteria because that's probably a moot point in this room. But I do want to make the point that most of the things on this list, as Dr. Moodley talked about, really show up in children. In fact, the only thing that we first see oftentimes in adults are the neurofibromas, the cutaneous neurofibromas and sometimes the plexiform neurofibromas. So typically it's cafe au lait macules that originally brings a child to our clinic to get a diagnosis. But we often say, your child may not have neurofibromas right now, but that's something that we will continue to monitor for as they get older. So this is just thank you to Dr. Moodley. I borrowed his slide here. So again, as you see, many of the things that we treat and we look out for and monitor for in NF1 are already present by the time an adult comes to our clinic. And I'm going to focus on some of the features that we need to look out for in adults. So this is, I think, the most important slide of all of my slides. And this is to point out that the vast majority of people with NF1 live long, happy, healthy lives. And really what we're doing is screening and monitoring. So the reason why I say this is one of my most important slides is that the slides to come will highlight some pretty scary things that we can see in NF1. But one of my jobs when I meet a new family is to really emphasize that we anticipate your child and your soon-to-be or eventually adult child will have a healthy life. And we're here to help maintain that and to make sure that that continues to be the case. The average lifespan for people with people with NF1 is actually the same as the general population. However, because there are things that we need to screen for and monitor for, it is important to continue to see a physician who's well-versed in NF1 and particularly to the things that we see in adults. And staying connected to an NF clinic also ensures that when new developments come down the road, like Koselugo or like other treatments that are in development now, you will be among the first to know and you'll have those treatments available to you. Okay. So what are the medical issues in adulthood? So as I mentioned before, cutaneous neurofibromas or dermal neurofibromas, those bumps on the skin, which often show up in late adolescence and adulthood. Plexiform neurofibromas, which we think are present at birth, but often become first evident in late childhood and adulthood. MPNSTs, which I'll talk about. Breast cancer, there are other cancers that we screen for, we have in mind. Hypertension, bone health, pain and itch, and then a topic that's going to be spoken about more later today, which is family planning and pregnancy. So to start with cutaneous neurofibromas, these are benign growths. These never become cancerous. That's a really important point that I make sure all our families hear about. But that said, they can be very, very bothersome. They can itch, they can be painful. If they're on a location like the scalp or under a watch band, they can get caught on things, they can bleed, and they can be very cosmetically disruptive. Almost all adults with NF1 will have cutaneous neurofibromas, but there's no way to predict whether someone will have 200, 2,000. There's no way to know, and there's a huge spectrum. They do increase with numbers in age. So the number of cutaneous neurofibromas do increase the older you get, is what I'm trying to say. So we often don't see any in young children. Typically, like I said, in adolescence, they start to appear, and you can continue to get more your entire life. So unlike cafe au lait macules, where by the time you're an adult, what you see is what you get, and actually those can often fade in adulthood. So if I see someone who's in their 40s or 50s who comes to my clinic, I might not actually see the cafe au lait macules at all. But unlike those, the cutaneous neurofibromas will continue to develop. Many people tell us that they've gotten more during pregnancy or that the ones that they had got larger in size. And we do think that they are triggered, growth of these lesions are triggered by high levels of progesterone. So that's a phenomenon that many people have experienced. There are options for removal. So typically those are surgical options. So either a skilled dermatologist or we prefer a plastic surgeon can take them off in the office. There are people who do laser ablation of these lesions and electrodesiccation. But right now, there's no medication that you can take to get rid of them all. That said, there are multiple clinical trials going on, and I think it's long past time for this to be a focus of research, and I'm really glad that the research community is turning to these. There's a lot of focus on plexiform neurofibromas because they can be life-threatening, but these can be, as many of you know, quite disruptive. And I think the future is bright, and we will have some better answers soon. Now, even without removing the cutaneous neurofibromas, there are medications available to treat itch and to treat pain. So this is something that you should definitely bring up with your physician if you're experiencing those. Plexiform neurofibromas, as I mentioned before, those are probably congenital, meaning we think that you're born with them, so you have them already at birth, but they can be really tiny. So sometimes we don't know that they're there until people get older or become adults and they start to grow or start to cause symptoms. There is a risk of malignant transformation, so that's why there's so much focus on these tumors, and the lifetime risk is probably about 10 to 15%. I think is this a pointer? There's a pointer, okay. So here, that's a plexiform neurofibroma there, and you can see a very large cafe au lait macule covering it, which is often the case. So when we see somebody with a very large or thickened or hairy cafe au lait spot, we will often feel it and check every time they come to make sure there's no plexiform underneath, or if there is a plexiform, that we're monitoring its growth. These are plexiforms all along the spinal cord, which you can see in what some people call spinal variant NF1. And here, that's a plexiform as well. So they can grow really anywhere that there's a nerve, there can be a plexiform neurofibroma. So the scary thing about plexiforms is, as I mentioned, they do have the potential to become malignant. Now, this is a small potential, right? 10 to 15% over a lifetime, but it is serious. These are extremely dangerous cancers, so we do keep a close eye on plexiform neurofibromas. When they do become malignancies, it's the sarcoma family of tumors, and they're almost always heralded by new symptoms, so particularly pain. In every single case that I can think of my patients who've had an MPNST, the first symptom that they had was pain. So they'll call and say, my plexiform used to hurt when I pressed on it, when I slept funny, but now it's hurting all the time. And that's a red flag for us that we need to look deeper and see if there's anything concerning going on. Rapid growth is the other symptom that we tell people to look out for. If it used to be a golf ball and now suddenly it's a football size, you need to tell us right away. Change in texture, so people will say it used to feel soft and now it feels kind of hard or rocky. That's a concerning feature. And any kind of new neurologic symptoms, new numbness, new weakness, and as I mentioned, pain especially. We do need to screen regularly, so when we know, like I said, that someone has a plexiform neurofibroma, we watch very carefully, but there's no consensus on what that screening entails. So these are from the ACMG, the American College of Medical Genetics. They put out recommendations in 2018 for the care of adults with NF1, but there's still no real answer. Does everyone with a plexiform need MRIs once a year? Is it just a physical exam? Do we need a PET scan periodically to look for any sign of malignancy? And because there's no guidance, no sort of established way to care for these, every clinic will do things a little bit differently. What we often do, if the plexiform is superficial, so you can see it, like on a face or an arm, for example, we'll usually rely mostly on our physical exam. If it's deeper or more internal, we will do MRIs periodically, and for some people who have very extensive neurofibromas, we'll do a PET exam or a PET scan every year, every 2 years, kind of depending, just so that we have a sense of whether there's any concern for malignancy. But again, I want to be clear that those are not established guidelines that everybody follows, so it is important to be seen in a center that has experience with NF1 and knows what to do with your plexiforms. There are other oncologic manifestations or other tumors and cancers that we can see in people with NF1, and this, by the way, is a PET scan. So here, where it's very bright, that is a plexiform that became a malignancy. And what I forgot to mention on the last slide is the average age of MPNST development is 33 to 35. So again, even though these are tumors that were present from childhood, and there are some older adolescents who do develop malignancies, it's usually in kind of early adulthood that it happens. There are other cancers that we see in NF1 at a higher rate than the average population, and that includes gliomas or brain tumors, pheochromocytomas, which I'll mention briefly, which are tumors of the adrenal gland, GIST or gastrointestinal stromal tumors, which are tumors of the intestines, and breast cancer. Overall, the risk of malignancy in NF1, the number that's cited in the 2018 paper is 15 to 20%. I've seen more recent numbers that say 30%, and that is a scary number, but keep in mind that the overall risk for cancer as of 2023 in the general population is about 23%. So even though the risk in NF1 is greater than the general population, it's not that much greater. The risk of high-grade gliomas or malignant brain tumors is also much higher than the general population, maybe even 50% higher, but that's 50% of a really tiny number. So the risk is higher, but it's not, super, super high. Breast cancer. So this is something that we talk about with all our women patients with NF1 because there is an increased risk compared to the general population. Any woman has a risk of breast cancer, lifetime risk of about 1 in 8, whereas the risk in NF1 is about 1 in 3, 30%, so significantly higher, and that's especially in younger women, so women under 40. The risk of breast cancer in the general population is primarily over 40, which is why we recommend that women over 40 should have annual mammograms, right? But in NF1, because we know the risk starts lower, especially in that 30 to 40-year age range, we recommend starting mammograms at age 30. And because at age 30, many women have dense breast tissue, and people with NF1 might have neurofibromas in their breasts, we also often recommend a breast ultrasound, so not only a mammogram, and depending on the person, your doctor might recommend a breast MRI as well to get a better view of what's going on. So the NCCN guidelines, the National Consortium of Cancer Networks, I think, it stands for something else, but it's the National Cancer Clinic Network, recommends annual mammograms starting at age 30. If you ever get pushback from your insurance saying, no, we're not going to pay for this because you're under 40, please have your doctor point to those NCCN guidelines because that's how we can make sure that those necessary tests are covered. After age 50, the risk of breast cancer is pretty much the same as everyone else, so those recommendations for an annual breast MRI kind of goes away, and it depends on your individual circumstance. Pheochromocytomas are, as I mentioned before, a tumor of the adrenal gland. These are rare, 0.1 to 5% of people with NF1, but they are exceedingly rare in people who don't have NF1. The average age, the median age, I should say, of when these tumors are developing is about 43. So these are tumors of kind of young to middle-age adults. I used to say 43 was middle age. I now say it's young. It all is based on how old I am at the time. And most often, they don't cause any symptoms at all. So if they're not causing any symptoms, you don't need to treat it. However, they can cause symptoms like high blood pressure, high heart rate, sweating, anxiety, and that's because your adrenal gland produces adrenaline, hence the name, right? So the symptoms of a pheochromocytoma are that fight and flight response, that high levels of adrenaline. So your heart is racing, your blood pressure is high, you feel sweaty and anxious. So if those symptoms come and go without any clear cause, again, please let your physicians know, and they may want to screen for a pheochromocytoma. If we see hypertension or high blood pressure in a person under 30 with NF1, screening for a pheochromocytoma is appropriate, and that's one of the steps we do before we just say, oh, take medication to control your blood pressure, like we might say in someone who doesn't have NF1. The screening test is a blood test, so it can be done in the office. But depending on the results, sometimes you need to do a follow-up 24-hour urine test where you'll get a big red collection bin and you have to collect all your urine for 24 hours. For most people with NF1, the blood test is enough. And if that's concerning, they'll often follow up with an MRI or other imaging tests to look and see if there's a pheochromocytoma. These can be treated with surgery, so they can usually be completely removed, or sometimes with medical management of the symptoms, so medication to lower blood pressure, heart rate, et cetera. Other malignancies that are higher in frequency in NF1, as I mentioned, are brain tumors. The most common brain tumors are low grade, so they are not malignant, but they can be problematic because the brain is a high value real estate area. But even if they're benign, they do need monitoring because, like I said, if they grow, eventually they may need to be taken out. And as I said before, malignant brain tumors are more common than the general population, but they are still rare. GIST, or gastrointestinal stromal tumors, are tumors that grow in the intestine. They can sometimes cause obstruction if they get large enough, so food can't pass through, and that can cause abdominal pain, changes in appetite, changes in bowel patterns. But unlike the general population, GIST tumors in NF1 are usually very slow growing and more benign. So I've had patients with NF1 and a GIST who've seen a general surgeon who kind of freaks out and says, we need to take this out right away. These can become malignant. Whereas in many patients with NF1, if they're not causing symptoms, we can just watch. So again, it's important. This is a theme that you'll hear running through my whole talk. It's important to be seen in a center that has experience with NF1. There are other tumors that might be more common in NF1. Thyroid cancer is one of them, but we're not entirely sure. And in general, there aren't any special screening for these specific tumors unless there are symptoms. However, your symptoms can really drive your workup. So if there's anything weird going on, anything new you're experiencing, keep a list, bring it to your doctor's appointment, and make sure they're aware. We do recommend limiting radiation exposure in NF1 because we know exposure to radiation can increase your risk of all kinds of tumors. That's the case for everyone, but that's especially the case in NF1. So that means if you're having a new symptom and someone tells you, oh, you should get an abdominal CT or a CAT scan, ask if an MRI would be an appropriate replacement. MRIs do not have any radiation exposure, CAT scans do. Sometimes you need a CAT scan, and if you have one or two in your life, that's okay. But if there's any way to avoid radiation exposure, we do recommend that. Another problem we see in adults with NF1 is hypertension, high blood pressure, and other vascular issues. And again, this is under kind of studied and not spoken about a lot when we talk about NF1, but it's important to keep in mind. We recommend that children and adults with NF1 have their blood pressure checked twice a year. So I usually say once a year with me, once a year with your primary care. Of course, that assumes that you have a primary care doctor, and that's also important, especially as children transition to adulthood. In the college age, many people stop seeing their doctors, and they'll come at 35 because their significant other made them come, and they'll say, well, I haven't seen a doctor since I turned 20 because that's when my pediatrician wouldn't see me anymore. But it is really important to have a regular doctor who can do just your normal screening that every adult needs to have. If there is high blood pressure, it's usually unrelated to a tumor or a mass or a compression of the arteries. It's usually just what we call essential hypertension. But in NF1, we do need to screen for those other causes. So pheochromocytoma I talked about already, renal artery stenosis where the blood vessels leading to the kidneys get narrow. That's a cause that we do see in NF1 and very rarely see in people who don't have NF1. So if there's any concern for that, you'll likely need an MR angiogram to look at those blood vessels going to the kidneys. Other blood vessels can become thickened and abnormal in NF1 as well. Usually it's asymptomatic, so it's not causing any problems. But people can develop problems like moya, which, as you heard from Dr. Moodley, can be narrowing of the blood vessels to the brain, aneurysms in the brain or the heart, and arterial venous malformations. So again, not to scare you, we don't necessarily screen everyone for this, but if there are any concerning symptoms, we may want to do an MRI or an MRA or other specific tests. Bone health is another topic that really arises only in adults. So we do have evidence that people with NF1 have decreased bone mineral density. This over here is a healthy bone, and this is courtesy of some website that I found it on. And this is a bone with osteoporosis where you can see degeneration. And the reason why this is important is osteoporosis can put you at risk for fractures. That's why older people who naturally have some degeneration of their bone are at such a high risk of fractures if they fall. And we think that people with NF1 start at a higher level of risk. The risk of fractures, in fact, is more than 5 times the general population in people over age 41, and we start seeing that osteoporosis in younger ages. We recommend vitamin D supplementation in our clinic. In full disclosure, the evidence for that is not great, but we feel like it's low risk enough that it's worthwhile to protect your bones, but not everyone makes that recommendation. And of course, if there is osteoporosis, then that should be treated aggressively or in anticipation of potential problems down the road. Neuropsychological symptoms are common in NF1, as we heard about in children, but also in adults. So depression is present in 30 to 55% of people with NF1. Anxiety is common, ADHD maybe even as high as 80%, and children with ADHD become adults with ADHD, and it can continue to become a challenge with things like family responsibilities, job responsibilities, et cetera. So it's important to consider treating if it's present. Some people with NF1 have cognitive impairment, which can affect their ability to live independently and to hold down a job, and that's something that we look out for very carefully. Children who have profound intellectual disability should have a guardianship discussion. So as they're reaching age 18, as their parent, if your doctor doesn't bring it up, please bring it up to them. How do we make sure that we can remain their legal guardian so suddenly they're not 19 years old and in a hospital and no one will talk to you as the parent because your child is officially an adult? That's something you need to think about. Headaches and migraines are more common in NF1. And for all of these symptoms, really screening and treating appropriately is important. The treatment is not necessarily different than in someone who doesn't have NF1, but it's just important to ask about these things or to bring them up if you experience them. And my last point there is to seek help when you need it, especially for things like depression and anxiety and ADHD, which can be often ignored in adults who feel like maybe they have other priorities or other things are more important. These are important health problems that can affect your quality of life, so please make sure to seek help if you need it. Pain and itch, so this can be related to known neurofibromas, but sometimes people with NF1 have pain or itchiness and we can't pinpoint a cause. And we think that's related to general nerve dysfunction or problems with nerve conduction that's inherently related to the nerves in people with NF1. Neuropathy, which can be shooting pain, tingling, pins and needles sensation, or can be painless, can happen in NF1, and these can be treated with medication, with physical therapy, or sometimes if it's related to specific neurofibroma, with surgery to remove the neurofibroma. Glomus tumors, which are a very rare kind of tumor that we see in NF1, are tumors under the nail bed and can be exquisitely painful. And what I've heard from patients is you see a plastic surgeon, they take it out, and the pain goes away instantaneously. So if you're experiencing that, make sure to bring it up because it is highly treatable. Scoliosis, so scoliosis typically develops in childhood. If you're an adult and coming to us and haven't had scoliosis before, it's extremely unlikely that you will develop it. But people who have scoliosis from childhood can have worsening of their symptoms as they become an adult, and it can start to cause pain. And that's really because of the asymmetric or abnormal strain on the muscles for someone who has scoliosis and is trying to compensate for that by leaning to one side or walking a little funny, and it can cause a lot of pain. So again, these are things that are important to screen for and we ask about at your annual visit with the NF clinic. And lastly, pregnancy and family planning, and my colleague Kara Ansett will be talking about that later today. We do start to bring this up in our older teenagers with NF1 because it's just important to know your options. I've had patients with NF1 who've come to Kara, our genetic counselor, to myself and said, well, I never knew I could have a child without NF1. And it's really important that people are aware of their options. So in terms of the family planning, there are many ways to have a family. There's no one right or wrong answer. But again, knowing what your options are is important, and Carol will talk more about that later. And that's based on the fact that for anyone with NF1, every child that they have has a 50% chance of inheriting their NF1. So that's a consideration that people want to think about when they're planning their future. When talking about pregnancy, so as I mentioned before, the number and size of cutaneous neurofibromas can increase during pregnancy, probably related to progesterone. So for people who are want to prevent becoming pregnant, consider not using a birth control option that's progesterone only. So that means like the Depo implants or the mini pill, which is progesterone only, that might increase your number of neurofibromas or increase the size of the ones that you have. IUDs that are progesterone eluting, like the Mirena, the Kyleena, are probably not a risk for increasing neurofibromas because the progesterone really stays in the uterus and doesn't sort of get out to the rest of the body. This comes up all the time, epidural anesthesia. I can't even tell you how many pregnant women or women who've had children and have NF1 have told us that their anesthesiologists refuse to give them an epidural. This is an outdated recommendation that is in the OBGYN and anesthesiology recommendations for managing labor and delivery. And I think the thought is that maybe there's a plexiform neurofibroma along the spine, and if they give an epidural injection and put a needle through it, that could cause problems. In fact, the risk is exceedingly low, and if you don't have any known plexiform neurofibroma in that area, there's no reason not to be given all the pain control options that every other woman is allowed to get. So we have a form letter that we write all the time, but it is important for women who are pregnant and want to consider epidural anesthesia to come and let us know, and we'll write you that letter. We'll talk to your anesthesiologist or your OBGYN. And there's no need for spinal imaging unless there's a clinical concern. We had a patient who was in active labor, and they made her go down and get an MRI of her spine before giving her an epidural. Yes, which is horrifying. So on that note, sorry to leave you on a really high note right there. My main point again is please make sure as you become adults, stay connected with an NF center. It's good for your health, and you'll also have access to care that you might not know about, like women who might not know that their anesthesiologist won't give them an epidural. Access to the newest developments in treatment of things like plexiform neurofibromas, like brain tumors, like cutaneous neurofibromas, And it helps us help you when you stay connected with us. So as things come up during the year, keep a list. Don't hesitate to reach out to your doctors with any concerns. And we'd love to continue keeping you healthy. So thank you very much. Oh, sure. I'm back.
Hi, guys.
No music this time. We will stay up here for a Q&A.
Hi, everybody. We have about 10 minutes for questions. So just a few rules. If you raise your hand, me or my cohort over there, Alana, will bring you the microphone. And please wait to ask your question until you get a microphone. So, right over there.
First of all, thank you guys both so much for coming and giving these talks and presenting this information to us, and also for the work you do as doctors. Thank you so much. Quick question is on the recommendation for exposure to radiation. I was curious if you guys could maybe elaborate a little bit on that, as sort of things to watch for, like for example, dental X-rays and stuff like that. Is that something that we should be careful about? And then second is, are there other things like that that are somewhat preventive in measure that we should be, as parents, watching out for as our kids grow up? Thanks.
Sure. I guess I'll tackle that since I brought it up. I opened the box. I'll try to close it. So, a certain amount of exposure to radiation is inevitable. We live on this earth. We have a sun. We're all exposed to radiation, but we try to at least minimize any excessive exposure. Dental X-rays are okay. They shield very well. You wear the thyroid shield and the lead apron. Dentists in general, my father-in-law is a dentist, have moved towards not X-raying as often. So if your dentist is still doing X-rays every 4 months or every 6 months, you might want to ask if that's actually the current recommendation, because most dentists are moving towards less frequent X-rays. Other X-rays, if your child falls and breaks their hand, it's okay. 1 X-ray is a very low dose of radiation. It's more like repeated exams that you want to avoid, especially CTs. So 1 chest CT is equivalent to 150 chest X-rays in terms of the amount of radiation. So again, if you need it, and for people with MPNST, I've had this conversation with oncologists who say that a chest CT is actually the best way to look for metastases to the lungs, so you can't really avoid it. If you need it, you need it, but at least try to minimize it. Other than that, you don't have to go crazy. You can stand in front of microwaves, we think. You can use cell phones. But it's these very large exposures like CT. Don't go to Chernobyl, I would say, in general. Those kinds of large exposures are the ones that you should avoid.
Yeah.
Okay. We have a question over here.
Minimize.
Hi, my name is William. As I get older, I itch terribly now. Very, very bad. Itch all the time. What is the cream or anything they can give you for that?
I wish I had an answer for you. Itch is really understudied and can be so debilitating. But again, it's one of those things where often physicians will say, well, it's not life-threatening, so suck it up, live with it. And I'm sorry on behalf of physicians everywhere. I apologize. For some people, medication like gabapentin or Cymbalta or Lyrica, which calms down nerve transmission, sometimes that can help. For some people, topical anti-itch creams like hydrocortisone can help. For most people with NF1, that's not a feasible solution because you might have neurofibromas everywhere, so you're not going to bathe in hydrocortisone or Benadryl cream. I have found that things like Benadryl and hydrocortisone tends not to work great for this kind of itch. And the nerve pain medications, Lyrica, Cymbalta, gabapentin, tend to work better. But that said, we don't have great options, and it doesn't work for everyone. I wish I had a better solution for you, and I'm hoping that science will step up in the next 5 to 10 years.
All right,
Have you tried gabapentin? Yeah. In my experience, gabapentin is the one drug that gave the best response. Although you can use the others as well. I don't know what you think, Devorah.
Yeah, I can't say that I found one's worked more than the other, but I also haven't studied it systematically. Some people say if they have one specific area that itches, things like cool compresses can help. It's maybe more of a distraction technique than actually treating the itch, but it can be helpful. But I don't have anything great to offer.
The other thing you can do is ask your doctor to check the tryptase levels for mast cell activation syndrome, because patients who have mast cell activation syndrome seem to have a higher burden of pruritus or itchiness. And if that's that, then you treat the mast cell problem.
Okay, we have another question over here. Hello. You were speaking on some of the cardiovascular issues with NF1. My question is, how would you recommend approaching your cardiologist as an NF patient when you're having issues and have been having issues on dizziness, heart rate fluctuations, such as, like, he diagnosed me recently with POTS, but we're having issues identifying truly the specific problems. We're having trouble narrowing down what this truly could be and if it is NF related and how we should move forward. How would you recommend approaching him from an NF standpoint?
So that's a really good point, a good question. I'm going to answer broadly before being specific. And the broad answer is, remember that people with NF1 can get all the same things that people without NF1 can get. And we tell that a lot to parents of young children who tend to be concerned that everything is NF. So I'll get a call, oh, he's pulling his ear and he has fever. Could it be his NF? And the answer is no, it's probably an ear infection because he's 5 and 5-year-olds get that. But I'm not making fun of anyone. I think when you have a large diagnosis, it's tempting to put everything under the umbrella of that diagnosis, and not everything is. But in this specific case, I would make sure that a pheochromocytoma is ruled out first, depending on what symptoms you have, because some of those can overlap. If it's not a pheochromocytoma, if it's not something like renal artery stenosis, and the testing all points to POTS, it probably is POTS. I don't know of any association with POTS and NF1. I haven't studied it myself. I don't know of it, but I would probably treat the POTS, which is postural orthostatic tachycardia syndrome, which is a syndrome where every time you stand up, your heart rate goes up and you can feel very dizzy and faint. I would treat that probably like anyone else with POTS. However, just make sure your cardiologist is, number one, aware that you have NF and is in contact with your NF specialist if that's relevant.
Yeah, I would agree with Dr. Devorah. I've been looking at the heart and NF1 for about 2 decades now. We've found at the Cleveland Clinic that the incidence of heart disease or vascular disease in patients with NF1 is around 9 to 10% of patients. So in my current clinic, every NF1 patient as part of the management gets a cardiac evaluation with an EKG and an echo so that we can catch them early. That's one point. The second point is that, I've been also dabbling with POTS for many years now. And POTS as an entity is not commoner in patients with NF1 than anyone else. But if you've ruled out a cardiac cause for the symptoms, it might be worthwhile getting a tilt table test on these patients. I have a couple of patients who have come to me with those problems, and they turned out to be POTS. And also I have had patients in general and in NF that have had COVID and then come back with symptoms that suggest POTS. And after ruling out all the common etiologies, we get a tilt table test, and I have several patients now with COVID and POTS, both NF1 and in the ordinary patients.
Okay, everybody, sorry we're running out of time, but I do want to remind you, if you have questions, you can put it in the Hoover app, and we'll get back to you as quick as we can. But thank you both so much. This was wonderful.
Thank you all.
Thank you.